Good afternoon, everyone. Thank you for joining us in this webinar presented by IMI's Big Data at Heart. My name is Dwayne Schultes. I'm the Managing Director of Vital Transformation. I'll be moderating this afternoon, and today's webinar is on the topic of the impact of COVID-19, long COVID, on cardiovascular disease. And again, thank you very much for being here. Before we get started, I just wanted to point out a couple little things before we get to our panel. If you're having difficulty with your internet connection, if you're having bandwidth problems, push the little button next to the mute, and there's a little arrow, and you will have this menu pop up. You can switch to the phone and dial in. We have several dozen phone numbers available for you that you can use, and they're toll free. So please feel free to dial in if you're having connectivity issues. We want your participation. As well, we do want your questions, and it's an exceptional panel of 6 experts that we absolutely are really pleased to have their participation today, and it'll be great to have your questions to them. So please feel free to use the Q&A bar in your menu. Just push the little button, the box pops up. You can submit your questions, and we'll be filtering those through as we work through the webinar. And again, please feel free to submit your questions. We will answer them as they come through. Cardiovascular disease plays a prominent role in the long-term impact of the COVID-19 pandemic. Patients with cardiovascular risk factors and pre-existing conditions have a significantly increased risk of developing serious long-term side effects. As well, COVID-19 patients in general regularly report serious cardiovascular complications. There has been a lack of long-term evidence to guide clinicians in the management of these often debilitating risk factors. There is a desperate need to rapidly understand the long-term COVID-19 pandemic. Coordinating data collection on a large scale is of pivotal importance. Big Data at Heart has invited several well-known researchers leading initiatives investigating the impacts of long COVID. We will share and discuss the results as well as exchange best practices during this webinar. And again, everybody, thank you very much. We'd like to introduce the panel now, and I'm very pleased first to introduce Big Data at Heart co-lead, Professor Dr. Volkert Alsenbergs, who's a professor of cardiovascular genetics and a cardiologist at the University Medical Center Utrecht, as well as a professor of precision medicine at University College London. Volkert, thank you very much, sir. We're also going to introduce, and we're very pleased to have Amitabh Banerjee, who's Associate Professor in Clinical Data Science and an Honorary Consulting Cardiologist at University College London. Amitabh, thank you very much, sir.
Thanks, Dwayne.
Also, another co-lead of the project, Professor Dietrich Grobe, Professor of Clinical Epidemiology, University Medical Center Utrecht. Rick, thank you very much for joining us today. Thank you, Rick. Also, we have Maureen Cronin, Dr. Maureen Cronin, former head of global medical affairs at Vifor Pharma. Maureen, thank you. How are you?
I'm good. Welcome.
And finally, Professor James DeLemos of internal medicine at the Division of Cardiology at University of Texas Southwestern Medical Center. Good morning, James. Thank you very much for joining us. It's early for you.
Thank you.
And should I say howdy?
Howdy.
Thanks, James. So to begin, I'd like to give the floor to Volkert, who's going to give us an introduction. Volkert, the floor is yours. Thank you very much.
Thanks, Dwayne. Just starting sharing my screen. All right. Yeah, I'm pleased to present to you the first results of the capacity registry. If people are interested, you can find detail on our registry on the capacity covid.eu for more information. We're glad that we're endorsed by a lot of international foundations that made it possible to start this registry and to maintain it as well. So as you all are aware, and was just mentioned as well, is that particularly in the first period of the pandemic, there was a lot of rumors, but there was a lot of discussion regarding the role and interaction between cardiovascular disease and COVID-19. There were some preliminary results from China, but also based on previous publications that there might be an interaction and there might be an increase in cardiovascular disease related to COVID-19, in particular myocarditis, and this is particularly due to a publication of several case series during that first period of the first wave, and there was not really data present at that time. The first data that came from the Western world was from the ISARIC, this is the global registry that looked into the COVID-19 and complications, and they found an increased risk for patients with chronic cardiac diseases and outcome and mortality. But if you look at the CRF, the case report form, it's quite limited, the granularity of the phenotyping of cardiac disease itself. And that was the reason that we founded Capacity in early March So to build upon the ISARIC electronic case report form and get more detail, so we added 400 specific variables, cardiovascular disease-related traits to the ISARIC electronic case report form to get more insights into the cardiovascular complications of COVID-19. So in total, 75 centers were included at first, and we have a total number of 13 countries that participated in capacity, and we now have a total of 12,000 patients included. I will show you the data, the first data of the first half of the capacity. We're still processing the remainder of the data. So here's the baselines. No surprises there. You've probably already known in literature from big registries. Mean age of 67, and of course, patients with a history of cardiac disease are older. There are more men. The body mass index on average is 28. A huge prevalence of diabetes and hypertension, and that's even higher in people, of course, with a history of cardiac disease, with even 66% prevalence of hypertension in those people. A lot of comorbidities like chronic kidney disease, COPD, and a less peripheral artery disease. So this is a bit of an overview of the capacity population that we included. And if you look at the complaints at admission, because that was one of the questions, well, do people with COVID-19 and pre-existing cardiac disease present differently to the hospitals? And that doesn't seem the case. So if you look at the typical symptoms of COVID-19, there's not really a significant differences between those two groups. If you look at chest pain, we thought, okay, maybe people presenting more with chest pain if they are already known with coronary heart disease and get COVID-19, but that's not the case in this registry. So that's reassuring. And if you look at the general outcome, if you compare that in red is the people with pre-existing cardiac disease, and in black is the overall population. If you look at the median duration of hospitalization, it's quite similar, and the same applies for the critical care unit stay. But you see far less patients admitted to the critical care unit in capacity COVID in comparison to the overall population. And that's due to the fact that people with pre-existing cardiovascular disease are elder, have more comorbidities. So I think less of those people were transferred to the critical care units pure due to an in-house prognosis. And if you look at the mortality figures, which are quite, they're huge. It's if it's 31% for people with pre-existing cardiac diseases versus 18%, and that's just the in-hospital mortality in capacity COVID. So these are really patients at high risk for mortality, and this is just for you to be aware. This is data predominantly from the first wave, not the second wave. So this is the first publication, which was just published this week. And if you look at the complication rate, the cardiac complications, it was quite limited. If you look at arrhythmias and conduction disorders, the numbers are quite low. There were no serious ventricular arrhythmias, only 14 patients. And if you look at myocarditis, which was one of the worries in the beginning, only 3 patients had myocarditis in the entire capacity COVID registry, according to the EEC definition. So that's quite limited. Heart failure, also pretty low incidence, and ischemia as well. So mortality is high, incidence of cardiovascular complication is low. If you look at other, is the thromboembolic. It's often mentioned in literature as well, right? That COVID-19 is more a thromboembolic disease. You can see a stroke is only 11, so 0.4%, but pulmonary emboli was quite frequent, 6.6% during hospitalization. And if you were admitted at the ICU, it was even 19%. So this is quite substantial. And if we looked into the relation or the association between pre-admission of use of oral anticoagulation for other indications like atrial fibrillation and outcome, we see the incidence is quite lower in comparison to people who didn't use oral anticoagulation at admittance. But there was no overall effect on mortality if you used oral anticoagulation at admission, hospital admission. But there are ongoing trials. One is from Fuster in Mount Sinai to look at the effect of the anticoagulation on the mortality as well. Of course, in Mount Sinai, they did find an effect on mortality, but in capacity, we didn't find any association. But it's quite an interesting study to follow. So of course, this is the question why we all started capacity, is to look into, okay, what's the effects of which patient, and that becomes now more and more relevant, I think, with the vaccinations coming up. So which kind of patients are at highest risk for mortality or complications. And if you look at crude univariate, any history of cardiac disease is quite related to mortality, to in-hospital mortality. But if you adjust it for age and sex, you can see that the association is quite attenuated. And if you do multivariable adjustment for 10 additional risk factors and comorbidities, it is almost null, except for valvular disease and heart failure. And heart failure has been already published by others as well. You can clearly see that there is an increased risk. It's non-significant still. But if we add the remainder of the capacity COVID registry, I expect that will be significant. But this is quite important information, because a lot of patients, probably in your countries as well, are staying home afraid to get COVID, or partners from people with, for example, coronary heart disease who underwent like a PCI 10 years ago. And I think the impact of those kind of cardiac diseases is quite limited. So except for, I think, for heart failure, that's, I think, is a high-risk population. So if you look at the capacity itself, I think there's a high mortality. It's an incredible number, high number, right? It's 31% in hospital mortality in the first wave in patients with pre-existing cardiac diseases. Important, the incidence of cardiac complication by itself, which is quite surprising, during hospital admission is low, maybe except for the pulmonary emboli. There was no difference in presenting complaints between cardiovascular disease and non-cardiovascular disease patients. As mentioned, high incidence of pulmonary emboli, but we really need RCTs to show benefit, also in the GP setting, hospital setting, and different settings to see whether we can reduce mortality as well. Known heart failure seems associated with worse outcome, not only by us, but also by others. But I think important is that we need additional studies to determine the benefit of routine cardiac screening. Of course, remember, capacity is just getting data from routine cardiac care. So there's a confounding, there's a bias by indication. So we need to find a way whether we should do echoes, for example, as a screening tool in everyone that enters that is admitted with COVID-19. And those studies are ongoing now. So that's, I think, important also for a next wave or maybe another pandemic. And of course, the long-term cardiovascular complications of patients will get more. Maybe for example, you see MRI studies now with late enhancement. We have to see whether there are some long-term cardiovascular complications related to it. But that, I think, that will be in due course. And I want to thank all the contributing centers and patients. Go to our website. We work according to the FAIR principles. So everything is open access. People can just apply for the data, and there will be a data access committee. And through a digital research environment, we'll make the data available to investigators. So just please join this effort.
Thank you very much, Volker. Wow, that's some interesting data. We do have a couple of questions that have already come in. We'll hold them. I do want to exercise a moderator privilege here. The pulmonary embolism data is striking. That's really quite amazing. Have you looked at any of the maybe genetic factors for people who carry a coagulation genetic biomarker like R factor laden? I mean, are they at a much, much higher risk? Have we done any segmentation work in there?
So capacity is really a routine care, right, registry. So we don't have any biosamples, but there are ongoing efforts, but also the UK Biobank. Of course, genetic data is available and it's enriched with the COVID-19 admissions. So hopefully we'll get more information from that.
Wow. Well, thank you. That's really interesting. Thank you very much, Volker. We're pressed for time, so we will continue. Amitabha, please, floor is yours. We look forward to your presentation. Thank you. And you're muted, so if you could unmute yourself, that would be great. Thank you.
Thanks very much, Dwayne. Thank you very much for the invitation to speak. My talk is about a calculator that we've been developing throughout the pandemic to help risk communication by the public, for the public during the pandemic. I'm a cardiologist and an associate professor at University College London. So just before lockdown in the UK, we published a preprint which ended up being published in The Lancet to show that if the infection rate rose to 10%. In the UK, there would be 35 to 70,000 deaths just in the high-risk group, which makes up 20% of the population. And that population includes those over 70 years of age and those with underlying conditions, notably cardiovascular disease and heart failure. This on the right here shows you in small print that the list of conditions was introduced on the 16th of March in the UK, and a further list of more vulnerable conditions such as severe COPD, people who are on active chemotherapy, was released on 22nd of March by the UK government. And we went into lockdown on the 23rd of March. We started then, aside from this analysis, thinking about how we could involve the public and patients in the dialogue to try and make people understand their risk of mortality in this COVID context. So we started working with a panel of 40 patients and public who have been involved throughout. And we developed the concept of a calculator, and we got feedback that actually this is ready for researchers, we're interested, but not ready for public consumption yet. And so we published the paper I just showed you in Lancet with a prototype researcher-facing calculator that the public could use. And that was used by 350,000 people in 24 hours. So there's an appetite for risk information that is there. So we kept user testing and getting feedback. And in the meantime, the landscape has changed dramatically. In the UK, we came out of lockdown. We had local lockdowns. Schools began opening in September. And at that time, we spoke with government who have been developing, I'll come to it in a second, their own commissioned calculator called Q-COVID, which is tied to government policy about whether you should be returning to work or going on public transport and so on. So we're now at the stage where we're talking with specialists, further user testing in a really wide group of patients, and we're also talking to data controllers with an aim to release this in December. The basis of this rather complex formula is that most of your risk of dying in the next year is tied to your baseline risk. The incremental risk of dying from COVID is related to the infection rate and your relative risk, which varies depending on your age, your underlying diseases, and so on. We have made a personalized risk estimate based on age, sex, underlying condition, and multimorbidity. And there's a list of 85 conditions that are from UK government. So we're drawing a line between UK government policy and big data from routine healthcare. I'm just showing you here, on the left is the government calculator, which is specifically looking at COVID mortality and a policy question, and it's not telling you anything about background risk or about long-term risk, whereas ours is comparing background risk with COVID mortality for public risk communication. This is where we're up to. On the left here, you have 4 clicks for your underlying condition, whether you have more than one condition, your age and your sex, and you press calculate risk, and it gives you a pictorial representation as well as your baseline risk and your risk projected during the pandemic. This is for somebody with no conditions. And just for an example here, I won't go through all 3 of these, but if you just look at the left-hand column, a 66-year-old man with heart failure and other conditions, let's say he's got kidney cancer, then his baseline risk is 6% of dying in the next year. And actually his pandemic mortality is 6.3, so only an increment of 0.3. So to Falkert's point that he raised, that actually not treating this gentleman's heart failure is going to be the problem this year, not COVID. And we also calculate the excess deaths. And on the right here, Q-COVID, which is the government calculator, shows you that COVID-associated mortality in this man is in the sub 0.1%. So, as I say, the plan is to release this to the public with disease-specific information. But we need to have a public conversation, at least in the UK, and I think it's the same in all of our constituent countries, about how we use data and how we communicate risk, and whether this should be available to people to see what their baseline risk is, so that they can inform their lives and their decisions. We've learned that doing public and patient engagement, even in the very unusual COVID context where a lot is done virtually, is not only possible, it's essential to doing this type of work. And we are talking to data controllers so that we can keep these estimates being reasonably continuously updated as we go along. I'll stop there. I'm happy to take questions.
Dwayne, you're muted.
Thank you very much. Amitabha, thank you very much. Has the government come to you, and has there been any comparison with your model versus their model? Is there any adaptation there?
So it's answering a different question. Thanks for the question, Dwayne. They're looking at 90-day mortality from COVID. We're interested in mortality over the next year, as I say, based on your baseline risk, and then a separate estimate for the incremental risk during the pandemic. But yes, we are talking with them.
That's great. Thank you very much. We've had a few questions come in, and again, we're going to continue to press on. Please use the Q&A bar. We will be getting to them quickly. Next, we have a joint presentation from Rick and Maureen, and I will pull that up momentarily here. There we go. It's coming. It's a lovely picture of Rick here. There we go.
Yeah, thanks.
Okay, thank you very much. Rick and Maureen, the floor is yours. Thank you.
Thanks very much. Indeed, Maureen and I will talk you through a couple of slides that introduce the COVID red product, which is about to start a big randomized trial. And Maureen will start with some of the background of this.
Yeah, hi. So my name is Maureen Cronin, and I'm a CMO of a small Swiss startup where we basically have developed an accurate at-home solution for women to use a wearable and big data AI approach to determining their fertile window. It basically consists of 3 elements: a bracelet, the women wear it only at night, collects about 3 million data points at night, intuitive app on a smartphone, and basically here you see a graph of some of the changes we see throughout the menstrual cycle that we're able to interpret to use to classify a woman's menstrual cycle. If we go to the next slide, you see this is the bracelet. This is how there's 3 sensors. One is a temperature sensor that measures skin temperature. The accelerometer we use to basically to cut out the noise of the data signals, but we also can use that to classify sleep. And then we have a PPG sensor that measures heart rate variability, breathing, and a couple of other things that we use also to look at data quality. Next slide. We've done a small study in women with premature rupture of the placental membranes to see if we could see early signs of infection. So when the pandemic started, we thought, well, gee, interesting. Perhaps we could actually reduce some of the burden in the healthcare system on testing and really try to funnel only those people towards testing that would need to, so to reduce cross-transmission rates and perhaps reduce the burden of the healthcare systems. So next slide. Rick and I then thought about this, and we approached the IMI, looked at their funding for an EU response, and out of this, we started the COVID Red Project. Rick?
Yes, the next slide shows you what this led to. This is the research question as it was formulated in the submission to EU, which was eventually granted. To use laboratory confirmed SARS-CoV-2 infection as the gold standard, we will determine the sensitivity, specificity, positive predictive value, negative predictive value for each of the following two algorithms. That is one algorithm using the AVA with the COVID Rat app, which collects data on symptoms and signs, or the algorithm using COVID Rat app data alone. So the interest was in the extent to which the data generates with predictions or time of prediction.
Rick, we're having technical problems. Maybe.
Yeah, Rick, we're really losing you, Rick. I'm very sorry.
Maybe if you turn
off. Maybe Maureen can take over then.
Okay. Yeah.
You might want to try turning off your video, Rick.
Yeah,
okay.
That's a shame. So basically, maybe let's go back one, Dwayne, make sure everyone has understood what the study's about. So basically, as Rick has already said, we're comparing the algo with the bracelet versus the algo only. And here we really want to understand if we can understand if, or really test actually, if adding the wearable to a symptom capturing app really adds additional benefit. A lot of times people perceive it does, but we really want to test it. And we want to integrate this in using clinical epidemiology strategies to really understand not only if it works better, but we're also doing a health economic check to make sure that actually this is benefiting society as well as individuals. Next slide. So classic to IMI projects, we've developed 8 different work packages to be able to achieve this. This is a very fast moving project. Since these are Rick's slides, I really don't know what he wanted to say totally here, and it's a little bit hard to see the entire slide. So I'm not going to bother you with all the work packages, but it's a complicated project. We have various different work packages that I already mentioned, the health economics one. Next slide, we're enrolling 20,000 people in this study, so it's quite complicated. But in the meantime, we weren't the only ones with the idea. Rick, are you back?
Yeah, maybe if you can hear me
okay,
well.
There you go. No.
Working, Dwayne?
No, you still really sound like a robot.
I'm very
sorry.
Yeah, we're losing you, Rick. It's unfortunate. Can you give this a shot?
Sure, someone? Of course. Yeah.
Thank you.
No, yeah. So I'll still keep going. Sorry about that, Rick. So in the meantime, we have, and I think many of us have already seen this, that aren't associated with the COVID Red study. There has been some research done with couple different groups publishing sensor data, trying to understand if we can use this remote monitoring capability to basically measure and monitor patients remotely. Here's one that was published in Digital Frontiers. Next slide, you can see some of the data. Basically what they wanted to do were look at all kinds of different clinical parameters, heart rate variability, recovery, heart rhythm, respiratory rate, PO2, and temp. And they basically wanted to see, again, similar to our idea, whether or not this makes sense. The idea, though, is what they've done in their publication is they've done a retrospective analysis. Different to our study, we're following our patients up prospectively. Next slide. Here's the early findings from the second study that has been published. This is the Fitbit study. Basically, they've already gone live with their results, and this has gotten a lot of press. They have indicated that they have ability and have developed an algorithm, and you'll see on the next slide, with fairly high specificity and sensitivity to be able to detect and predict the need for hospitalization. So here you see their ability to actually predict before. So if you look at the graph here on the right, you see day 0 is actually the day when they start developing symptoms. And then the colored graphs on the right, you see the darker red line for breathing rate, the orange for heart rate, and heart rate variability in blue. And here we see a very typical pattern that actually these biophysical parameters start changing before the patients perceive their clinical symptoms. And in fact, we're seeing here in their study up to 4 days before the clinical symptoms. And they're reporting an accuracy of 77% to be able to predict illness. Next slide. Here again, this is the data points we're, of course, with a wearable interested to see if we're seeing before clinical symptoms start, to see if we're able to detect a probable or possible infection. Next slide. One of the big questions will be, is this what kind of infection this is? So we set up then our study. Basically, here's the setup. It's kind of an interesting study. We initially wanted to do 40,000, and then we thought of a good way to do this easier and more efficiently. We're enrolling 20,000 patients. 7,000 of them are high-risk patients, 13,000 from the general public, and we're going to use a crossover design. But the crossover is, as Rick already indicated early on, is that we will actually just use the data for the symptom tracking app, when we will compare that to the added value of what the wearable does. The people will be sampled early on at the beginning of the study, so we can retrospectively go back at the end to see if they actually brought COVID into the study. And at the end, we'll also test again to see what their antibody status is, to see if we missed a COVID infection during the study. Patients or people who do develop symptoms will be tested with PCR during the study according to the national Dutch recommendations. Next slide. How we developed the algorithm is basically very similar to what you saw with the Fitbit. So we also did a retrospective analysis. We looked in our current user data set and asked women to report to us if they had had fever. And we also asked them, have they been tested or did they have symptoms of COVID? We got a response from about 100 people. 30 of them told us that they were suspected or were confirmed COVID users. We, in the next slide, you'll see, found similar results to what Fitbit has published. So we also saw changes in the biophysical parameters before actually the reported symptoms. This is just one case. In the meantime, we have 100 COVID cases, so about 3 times the number of patients in the Fitbit study. And we're now in the final stages of our second iteration of our algo that will be COVID specific. We started with a infection specific or generalized algo, and now we're specifying it for COVID. And then we'll go live with this algo in our study. We also repurposed, next slide, our app. As you can see, click again. No, go forward, Dwayne. You can see it's basically a self-instruction app, very few slides. It's explained. They log by clicking simply on the body part where they want to do it, where they want to report something, and they have a pull-down menu, so we have very specific symptoms. We also give them the ability to develop a custom log if they want to add information. One of the most important things with wearable data is you have to realize there are confounders for these biophysical parameters. So of course, if they have fever, they've taken the antipyretic, if they've drank a lot of alcohol. So we also have a daily log so that they can report their confounders. On the right, you can kind of see the summary data, what they get on a daily basis, so they can also track how their parameters change over time. And in the next slide, this is what happens. And this is really quite what's unique about our study compared to some of the studies that have been presented out there. They will then be getting a real-time indicator of their potential infection during the study. So you see on the left, this is the indicator they would get after syncing the app in the morning. Okay, everything seems to be fine. And then we have several other different apps saying, there's something that's maybe indicating change. You might want to consider self-isolating today and sync again tomorrow. The second version of that would be, hey, there's something here that might suggest something's going on. You should really report to your healthcare provider to get a test. Okay, next slide. So that's the study. I'll show you the timeline in a second, but we really want to highlight that we were one of the fortunate few. Out of 200 projects, only 8 got funding from the first wave of IMI. So we're very pleased to say that, you know, we've been supported by the European Union here. Next slide. Here's the timeline. So we started off with a small pilot study. In Liechtenstein, we're now integrating, as I said, those data into the second version of the app. And we're kicking off the clinical phase in December of this year. And we intend to be finished by June and analyze the data in fall and December. You might ask yourself, given this timing, well, okay, maybe we'll have vaccines and this isn't important. I don't believe that's the case. I think with the vaccine, we will have a number of people who won't get vaccinated, and it will be also interesting to see how people might do with the vaccination, to continue to monitor them in their home settings to see if the vaccines are actually working. One of the most interesting aspects, though, is people who have been vaccinated or who've been sick can continue to utilize the device to look at their long-term health consequences. So we also come back to the topic of this presentation. So we know the long haulers are out there, and we believe that this remote monitoring device will also help us monitor patients within their home setting to see what potential long-term consequences of a COVID infection on their biophysical parameters. And if we combine that with some of the other things we're looking at in the study, we believe we'll also have rich data to analyze for this. Last slide, I believe. Here's an overview of all of our collaborators. As I can't, we don't want to waste the time to talk about them, but it's quite an extensive group of people. It's a very exciting project, and we look forward to being able to present the results mid next year and then the final paper at the end of next year. Thank you.
Thank you very much. So you go live in December and you're going to have data already in June. That's 20,000 recruitment. That's very, very ambitious, Maureen. How's that going to go?
Well, good. We know that, and there's a lot of people from, and Rick is really the best person to speak to this, but trials at home, we know virtual studies are the way to go, certainly in the COVID. We know with social media, we'll get people signed up very quickly to this. Of course, we'll also try to embed it, as we did in Liechtenstein, into an existing cohort. There we started with a cardiovascular existing cohort to get some of the initial data and test the study concept. Rick is also proposing to do that in several existing cohorts in the Netherlands, but we believe in particular healthcare providers, that 7,000 group, that group of 7,000 who are really at the front lines of this disease will be fairly easy to recruit, and we'll also try to have generalizable population, but also look at universities to try to recruit some of the younger people, because it's not only the higher risk patients that we've been talking about in Ami's presentation, but also the younger. So yeah, we trust we'll get it done, but it's a challenge.
Thank you very much, Maureen. Our final presentation now is from James Delamos. James, floor is yours. Thank you very much.
Okay, Rick, is this the right screen here?
It looks fine for us. Looks really good.
All right. Well, thanks everybody for your attention today. I'd like to talk about the American Heart Association's COVID-19 Cardiovascular Registry. I'm co-chair of the steering committee for this registry. As of November 9th, we've enrolled 109 hospitals and medical centers in about 35 US states. We have over 22,500 patient records and growing by about 1,000 records per week. We collect 200 data fields per patient. One of the unique features of this registry is we're collecting extensive serial laboratory data. We've got more than 75,000 days of serial labs, and we've received 55 research proposals to date. 21 of them are active. Much like what Volker talked about with capacity, we also felt the need to disrupt and democratize the research process, realizing that clinicians need data in a much shorter time frame than a registry typically delivers that. And to do this, we leverage the AHA's precision medicine platform, which is a secure-based environment that allows dozens of teams of investigators to work in parallel on the same curated and de-identified data set with some support from AHA data scientists, but a collaborative approach from the different analysts and a learn as we go approach. As would be expected, this markedly shortens the time to discovery and dissemination of results. We're 6 months into the launch of the registry and presented 3 abstracts and had 2 publications at American Heart Association. Lowers the cost dramatically per paper or unit of research. And the other big advantage is it leverages the talent and energy of a much larger group of investigators relative to a typical registry, which is centrally organized. Number of challenges as well include the need to maintain rigor despite less central control, the unprecedented pace, and the obvious conflicting commitments of the individuals at the sites who are obviously being deluged with COVID patients. The data I'll show come from several different data cuts. What I'll show for the cardiovascular outcomes is a data cut through the end of September, which is about 100 sites and 15,000 patients. What you can see is that the vast majority of COVID admissions in the US have cardiovascular risk factors. Only about 13% had no risk factors. Hypertension in almost 60%, obesity in 45%, and diabetes and hyperlipidemia in about 35% each. Remarkably consistent findings in the US relative to what Volkert reported across 13 European countries from capacity, namely that the individual cardiac events are relatively uncommon, are composite in about 8%, but MI rates almost identical really to what Volkert reported in Europe. MI rates under 5%, stroke under 2%, heart failure almost identically at 1.8%, myocarditis at 0.3%. We do observe an even lower rate of DVT and PE than is observed in capacity, possibly because of less active surveillance, but also likely because we enrolled patients in a little bit later phase of the illness when US centers had learned from the European and Chinese experience about high rates and were using more frequent DVT prophylaxis, even at higher doses than typically used. Also, we see remarkably similar rates of mortality, 16.7% through end of September, with another 3% referred for hospice. And the vast majority of this is respiratory. Only about 10% of the deaths are from cardiac causes. We presented and published simultaneously in circulation 2 additional papers, one focusing on race ethnicity in the US, and this is a very distressing story. What you can see in red are the data from the registry, and in gray, data from local census tracts of the hospitals that enroll patients. And what you can see is that the proportion of Black and Hispanic individuals enrolled dramatically overrepresents the Black and Hispanic proportions in the communities that these hospitals come from. In contrast, when we looked at adjusted rates of in-hospital mortality, and this is adjusting for clinical factors, demographic factors, and disease treatments, there were no differences by race ethnicity in in-hospital mortality or in major adverse cardiac events. There was a slightly higher rate of COVID disease severity based on the WHO index in Asian patients, but no difference in Black or Hispanic patients. I don't want to provide a misleading message when considering the massive increase in the proportion of Black and Hispanic individuals enrolled. This similar mortality still translates into dramatic excess in the burden of death and major cardiac events that occur among Black and Hispanic patients in the US. The other abstract we presented focused on obesity, and shown here are comparisons of the registry versus a normalized US population sample from NHANES. And what you can see is that the individuals hospitalized with COVID are notably more obese, with about an 11% probability of severe obesity and a greater than 50% probability of overweight or obesity. Most striking is when we look at the younger group of individuals, less than 50. The proportion obese relative to NHANES is much greater, and the proportion with severe obesity, a BMI above 40, is double relative to a similar age subset of the US population. When we look at the characteristics by obesity classes, several striking messages. First, the group with severe obesity is hospitalized with COVID at an average age almost 20 years younger than the normal weight individuals, dramatically overrepresented in Black and moderately overrepresented in Hispanic patients. When we look at body mass index and the adjusted rates of adverse outcomes, the composite of death or need for mechanical ventilation increases beginning at class 1 obesity in a stepwise fashion, with an almost doubling in the risk after adjustment for class 3 obesity. The story with regard to death also shows a significant increase, but only in the group of class 3 obesity. But this most striking and steep association is observed with the individual component of mechanical ventilation. When we, probably the biggest take-home message from this analysis was that there was a statistical interaction by age such that the hazards of obesity were magnified in young people. Shown on the left is here is the composite of death or mechanical ventilation across age less than 50, 51 to 70, and greater than 70, and with higher BMI on the x-axis. And you can see that the adjusted hazard for death or mechanical ventilation is much steeper in those less than 50 than middle age or older adults, and the older adults showed no association. When we look at mortality, only the group less than 50 had a significant excess in mortality with BMIs above 40, with no association in middle age or older adults. Now, for mechanical ventilation, the hazards of obesity appeared present in all age groups, but the magnitude of the association was greater in those less than 50. So to conclude, COVID has catalyzed disruptive and likely enduring innovations to registry research. I think Folkert is reporting and made similar adaptations to registry research in Europe, and certainly we're doing the same in the US. It's validating, certainly, to the methodology, but also humbling that the burden of COVID with regard to hospital mortality is so consistently terrible in multiple countries across the world, with a virtually identical 16 to 18% mortality rate. And very similar conclusions that the major morbidity and mortality is largely non-cardiac, and that the cardiac complications, now that we're providing results from generalized registries, are less common than we feared. Now, we also observed that while race ethnicity was not independently associated with adverse events, more than 50% of the hospital deaths occurred in Black and Hispanic individuals. But because the in-hospital outcomes are similar, in the US, it reminds us that interventions to reduce race-ethnic disparities are going to have to focus upstream on the social determinants of health and the structural racism and other factors that drive these health inequities. I think a very important take-home message that's likely relevant worldwide is that the relative hazards of obesity for death and mechanical ventilation are greater among younger patients. And as COVID surges worldwide, we really need clear public health messaging for younger obese individuals who may get the incorrect message that because they're young, their risks of major complications may be low. Thanks for your attention.
Thank you very much. We do have a few minutes left for questions. Seems that we had the question bar has been sort of cleared out. People on the panel have been answering them as they've been coming in. So if people have a few more questions you'd like to submit, please go to your Q&A button, submit the questions, and we'll be circulating them to the panel as we go through in the last 10 minutes or so. One of the challenges that we have regarding any evidence related to COVID-19 is the politicization of the examples in public trust. If you look at masks, CDC and WHO said masks were not effective. They had that on their website. Then they were saying you had to wear masks. Now there was the Danish study that just came out that puts the effectiveness of masks into question. What do we deal with how do we deal with any breakthrough to make sure that these are not politicized and we have public trust? Anything that we're talking about now, how do we make sure that these are adopted and are not politicized? James, I'll start with you since you presented last. How do we make sure that these messages around obesity and age are communicated correctly in a way that aren't, manipulated or politicized?
Yeah, it's a very difficult challenge, certainly in the US, that somehow the mask debate has been perverted into a political debate, which makes no sense.
No sense at all.
And I think, fortunately, we look ready for a transition in the US to leadership that will put science first and hopefully take politics out of public health. We were hit grossly unprepared in the US, and it made, there were terrible leadership mistakes made, in my opinion, that have contributed to this. But moving forward, I think people have to regardless of their political views, have to separate out public health from, personal choice and personal freedoms, and recognize that we all have a responsibility to others around us. And that's no different than other decisions we're asked to make living in societies that are ruled by law. It makes, to me, it's tragic and makes no sense. So it's kind of hard for me to understand how this has happened.
Volker, the Dutch have had quite a sober approach, particularly to schools, keeping schools open. They published quite a robust study that looked and analyzed at children passing disease state through families, et cetera. And the Dutch have kept schools open. Why do you think the Dutch have had a more sober approach to a lot of these decisions that have become politicized?
I'm not a public health expert. I'm not a policy maker as well. So just let's get back to what James was mentioning. And I think it's most important is, and I think this really what you're mentioning, this topic is that confirms that we have to just make sure that we jointly do this kind of research together with the patient and public, right? So I think involvement is key, right? From the start. I think James did it as well for his registry. So we included patients, but also public immediately from the start off in the UK, but also in the capacity global, to think about the relevant questions. But also that will help you to give you channels, right? Trusted channels, right? To spread your message as well. Because I think what we all agree upon is, I think we still need the traditional journals, etc. But then you don't reach the right audience, right? Specifically in this pandemic. And what I'm still struggling with, so we went through a peer review, right, process like we all do, but then the results rate came just public like this week, while we already had it submitted 3-4 months ago. So we need to think of a new shift as well. And I think these pre-publications repositories will help, so that we just publish, but then review on the fly. Because I think what I've learned from this pandemic, we don't have that much time. We need to have more open science, but we have to be careful that there's no garbage as well.
Yeah.
So I don't know. I'm just curious about opinion by others, but I think that's something that I'm struggling with, because you want to have
the preprint issue is a tough one. I hear you, because you want to see it, but then you also want to make sure that there's validation there behind it as well. Yeah. Amitivo, from your perspective, I mean, you're in the UK, and the UK has sort of been the US. It's been a basket case as far as politics around this. How are you dealing with this soberly as a practitioner?
I tend to agree with what's just been said, that on the research side, we have to take public with us. I think we use this word politics, I think wrongly. It's not politics that's here. It's the problem is that the information has to be from trusted sources. And we need to, as members of the public and patients and specialists, think about that. I'm a cardiologist. I think twice about giving a gastroenterology opinion. So why am I listening to radio talk show hosts and TV talk show hosts to tell me what to do with my mask and what to do with COVID vaccinations? So I think people should be honest about the limitations and honest about their trust, and know who to trust. That's where the misinformation is coming from. That's not politics.
Maureen, from someone who has legs similar to I do in Europe and the US, I mean, you live in Switzerland, you live in the US. How do you see the difference from your side as what you're trying to do on the clinical research?
Yeah, well, it's tough for me to talk about the research world in the US right now. I'm just a visitor. I do believe that the political discussion is really, really, really different. And yeah, it's a little bit hard not to be too political in the statement. It is kind of surprising to see what's going on right now. And I think, as James pointed out, I think we'll see the US coming back into the space where we all feel comfortable and it's science driven. I think one of the things about this is what the point that also Ami made in his presentation is that we're also seeing, as if I'm misquoting you, Ami, please jump in and correct, but a lot of patients really aren't getting the critical care they need, in particular in the cardiovascular space. One of the implications of the pandemic is that we're lumping everyone together in risk factor groups and not really differentiating who really maybe should weigh the risk of the potential infection versus not getting the critical care. So it's really good to get back to the science. That's the kind of messaging we really need to figure out what the guidance is and where we want to go as a community, and how we can use big data approaches to really clarify some of that. And so I certainly would like to, also ask some of the other panelists on here. It's really a shame Rick had the bad connection. I think one point also just the research. What we're so extremely forced to do now in COVID is all this remote monitoring, figuring out new ways to do research. Certainly the US is there a little bit advanced with informed consent. Europe is playing a little bit of a catch up here. If it's a plea to all of us, we really need to think about in more intelligent ways to do research, and we have a lot more technology to support that. And we believe that the quick turnaround that Volker was talking about is a lot easier if we can let go of some of the historic ways to do it and really just try to go fast, but correct.
Rick, can we give it a shot? Can you chime in a little bit about trials at home? How are you doing there?
I'm not sure the internet works right now. Can you hear me well?
It's borderline. Why don't you give it a crack, though? Can you just do your trials at home pitch?
Trials at Home is another EU IMI project, but a big consortium. Of course, much promoted by what's happening currently. We're looking into ways to run trials as remote as possible. So bring the trials to patients rather than patients to trials, using a range of innovative technologies, some of which we're going to apply already in COVID-RET, and some of which is still being selected and prepared for a pilot remote study we're going to run in Europe to test these technologies and see whether they are fit for use and also acceptable to regulators.
Thanks, Rick. That worked for us. Thank you. We pushed our luck and we got through it. That's great. Thank you. We have a question here from a Christine Den. What about long-term implications of COVID? And I'm sorry, this just jumped because it would appear that someone answered it. Yeah. Long-term implications for heart disease and endocarditis after a couple months after a COVID infection. So some of the real heart conditions that we're seeing. Go ahead, Volker. You answered it. Jump in, please.
No. So what we try to do is with linkage, right, with national data, with hospital data. But I think this long-term complication is really important. As James and I mentioned, right, there's no short-term, but we're not really sure whether there's some fibrosis ongoing, right? There are some MRI studies from Germany, but also from the US that showed some late announcement that what I mentioned, and maybe it has some long-term implications. Personally, I don't think so, but we have to see. So I think it's really important that also in 5 years' time, we still do linkage to outcome.
That's great. James, you're nodding. Do you have anything to add?
I agree. I think it's the question, right? With 25 to 40% of patients having cardiac injury with troponins and a substantial proportion having MRI abnormalities. The question is, are there any long-term implications of this, or are we just sort of detecting a signal that has no long-term cardiac implications? But I think it's going to be 6-12 months before you have any reliable data on this.
There was recently there was a study just last week from St. Jude Medical where they found that it wasn't a CRS that's actually driving a lot of the cardiovascular hyperinflammatory immune response, but it's a panoptosis associated to caspase 8 and STAT1 protein. So it's a different response mechanism. Boy, I'd love to dig into that, but we're running out of time, unfortunately.
But it's an important point, Dwayne, because if there is something which is related to the troponin release now or to the fibrosis, right, then we get a pandemic afterwards, right? So that's right. It's a really important point.
But it's also a new channel that we're discovering that we didn't know before, and that could also then lead to new T cell research or other things. I mean, who knows where this is going to go? Boy, a lot we could dig into there, but unfortunately we're down to our last minute. It's hard to believe we've gone through this hour. I do have one final question, just quickly from all of you, and I'll start with you, Maureen. Where do you think we're going to be a year from now, December 21, looking at COVID-19, given what we're working on here with Big Data at Heart. Maureen, from your perspective.
Yeah, I think we're spending a lot of time understanding the benefit risk of the new vaccines and understanding their public use and acceptance. I think there's a lot of work ahead. We're glad to have them, but there's a lot of work in front of us.
Thank you. Amitabha, from your perspective, where do you think we'll be?
Thanks, Dwayne. I think there's three things. Firstly, we've learned that non-communicable diseases, including cardiovascular disease, are part of the response and the preparedness for a pandemic. So we need to do that better next time. I think we've learned, as Maureen says, not just we'll have to look at what's happening with the vaccine, but long COVID and cardiac complications and other organ consequences we may be dealing with. And then finally, I think the effects on indirect things in the health service, cancelled operations and so on, is going to be major across all of our countries. And we're going to be chasing that for at least the next year or so.
Rick, should we push our luck? What do you think, Rick?
Yeah, just very briefly, I think we've come a long way a year from now in detection and prevention by vaccination. I'm just worried that we've shifted the burden of the problem to the global south at that point in time, because there's a real concern that what we can achieve here will never be achievable for like 60% of the world's population. We have to think about that very carefully.
7 months to an mRNA is pretty astounding. You're right. James, from your perspective?
I agree. I think acute COVID will be in our rearview mirror by in a year. I think the vaccines the data are remarkable, and assuming we can avoid politicization of the vaccines, then we'll achieve herd immunity, and we'll be talking about economic and recovery from COVID, and whether these long-term effects are common and how important they are. But I don't think we'll be dealing with acute infection in here.
Volker, last word to you, sir.
I agree with all the statements. In addition, we also need to look what's the effect of vaccination, right? In particular, patients, right? We all focus on prioritization, but we also have to look the other way around, right? To see what's the effect in certain subgroups.
Ladies and gentlemen, we could have gone much longer, but we're out of time. I'd really like to thank the panel. Everyone, thank you very much. For the audience, thank you for your participation. I'd like to thank Big Data at Heart for their support. And with that, we call this webinar closed. Thank you very much, everybody. Have a good afternoon. Bye-bye.
Thank you, Dwayne.
Cheers, everyone.